Hello viewers, I am Dr. Raviul. I work as a lecturer of pathology in a medical college hospital and I am making this video for my students and also for you. Hope someone finds this helpful. Today's topic is on tumors of the esophagus part 2, and in this lecture we will talk about squamous cell carcinoma of the esophagus. We will discuss about its epidemiology, pathogenesis, morphology, clinical features, laboratory diagnosis and treatment. And also at the end of this lecture we will also briefly talk about the TNM staging system. Okay, a lot of topics, so let's begin. First question, what do we mean by squamous cell carcinoma of the esophagus? Now recall from my previous video on tumors of the esophagus, we had seen that the wall of the esophagus has 4 layers. And if we think of them from inwards to outwards, they are mucosa, then beneath the mucosa there is submucosa, then there is muscle layer that includes inner circular and outer longitudinal muscle layers, and at the end the outermost layer is adventitia. And we had also seen that in the mucosa there was 3 components. There was the stratified squamous epithelium, beneath that there was lamina propria, and also there was some muscles in the mucosa, and those muscle layers are referred to as muscularis mucosa. So we can see that the lining epithelium of the esophagus is in fact squamous cell, right? And these cells are flattened and they are arranged in multiple layers, and that's why they are called stratified. Always remember, stratified means multiple layers. So we know that the lining epithelium that is covering the mucosa of the esophagus is stratified squamous epithelium. And if I want to be more specific, it is non-keratinized stratified squamous epithelium. And whenever there is a malignancy or carcinoma arising in these squamous cells, that is resulting in squamous cell carcinoma of the esophagus. So now that we have talked about the basic concept of squamous cell carcinoma, let's move on and talk about the epidemiology. As you can see, squamous cell carcinoma of the esophagus occurs more frequently in adults who are older than 45 years, and it is also more frequent in males compared to females. For example, in the United States, it is 4 times more frequent in males than in females. So, regarding the epidemiology, also we have to know that highest incidence is seen in Iran, Central China, Hong Kong, Brazil, South Africa, Western Kenya, and also in areas where there is regular ingestion of very hot tea. And regarding Western Kenya, always remember that it is particularly seen in certain regions of Western Kenya where there is regular consumption of a drink that is called mursik, and it contains carcinogenic compound like acetaldehyde, and that can result in esophageal carcinoma, particularly squamous cell carcinoma of the esophagus. So these informations are important for your multiple choice questions. You may have a stem where it is written highest incidence of squamous cell carcinoma of the esophagus is seen in the following countries, and then you have to know the regions and the countries. So now let's talk about the risk factors of squamous cell carcinoma of the esophagus. And as you can see, I have written a lot of risk factors, and we will talk about these risk factors one by one. But to summarize, always remember the risk factors that can lead to development of squamous cell carcinoma of the esophagus include tobacco, alcohol consumption, caustic esophageal injury, achalasia, Plummer-Vinson syndrome, diets that are deficient in fruits or vegetables, frequent consumption of very hot tea, previous radiation to the mediastinum, and we have already mentioned this, consumption of our traditional fermented milk known as mursik, and this is particularly seen in Western Kenya. So now let's talk about these various risk factors one by one. The first risk factor that we will talk about is regarding tobacco. Now always remember, tobacco contains a lot of chemical components, and many of these chemical components are carcinogenic. Now, one component that is specifically responsible for causing esophageal cancer is known as triple N, or it is also known as N-nitrosonornicotine. This component is found in tobacco, and this is specifically responsible for development of esophageal cancer. And also remember that tobacco contains nicotine that is strongly addictive. Nicotine binds with nicotinic acetylcholine receptor in the brain, and that can result in release of catecholamines, and that can cause increase in heart rate, blood pressure, cardiac output, and also it is strongly addictive. So the individual who is consuming tobacco becomes addicted to this tobacco, and so he is consuming more and more tobacco, and those carcinogenic compounds are causing further damage. Now also remember, besides the triple N or N-nitrosonornicotine, there are other potent carcinogens present in tobacco, and they include polycyclic aromatic hydrocarbon, nitrosamine, aromatic amines, etc. Now, if the individual is consuming tobacco and alcohol at the same time, the risk becomes even higher. So always remember that tobacco and alcohol consumption both can result in development of esophageal cancer in the long run, and if the individual is both alcoholic and also consuming tobacco, the risk becomes even higher. The next risk factor that we will talk about is caustic esophageal injury. That means here there is damage to the esophagus, and this is happening as a result of ingestion of caustic substances. Now, these caustic substances are ingested either accidentally or intentionally. It is usually ingested accidentally by children. For example, common drain cleaners or other household cleaning products or disk batteries, they contain sodium or potassium hydroxide. These are strong alkali, and they are the most common cause of such caustic esophageal injury. And children can consume these substances accidentally. However, in case of adults, when certain individual has an intention of committing suicide, they may ingest these things intentionally. So always remember that caustic substances can damage the esophagus, and in the long run, it can also result in esophageal cancer, esophageal squamous cell carcinoma. The next risk factor is achalasia, and I have an entire video on achalasia, so you can also look into that video after watching this video to know more about achalasia. But always remember, in achalasia, the lower esophageal sphincter is failing to relax, and that is causing a lot of pathology, and ultimately that can lead to development of squamous cell carcinoma of the esophagus. The next risk factor is Plummer-Vinson syndrome, and whenever you hear this term syndrome, always remember that syndrome means symptom complex. So what is happening in Plummer-Vinson syndrome? There is iron deficiency anemia, there is esophageal web, these are ledge-like protrusion of esophageal wall towards the lumen, there is inflammation of the tongue that is known as glossitis, and also there is fissuring of the lips that is known as cheilosis. So all these things are happening in Plummer-Vinson syndrome, and you may often have short note on Plummer-Vinson syndrome from other chapters. But always remember that Plummer-Vinson syndrome, individuals with Plummer-Vinson syndrome are at risk of developing esophageal cancer, esophageal squamous cell carcinoma in the long run. The next risk factor that we will talk about is diet that is deficient in fruits and vegetables. Now, in many studies, it has been seen that individuals who have taken sufficient amount of fruits and vegetables in their diet, they have a lot of health benefits. They have higher levels of fibers, beta-carotene, folate, vitamin B6, vitamin C, etc. in their diet, and these nutrients have protective role, and these individuals have less risk of developing esophageal cancer as well as gastric cancer. On the contrary, individuals who has less amount of fruits and vegetables in their diet and individuals who are taking more animal protein in their diet, they have higher risk of developing esophageal and gastric cancer. So always remember that taking sufficient amount of fruits and vegetables may lower the risk of development of esophageal as well as gastric or stomach cancer, and high intake of nutrients that are found primarily in foods of animal origin, they can increase the risk of esophageal and gastric cancer. The next risk factor is previous history of radiation exposure to the mediastinum, and in these individuals there may be development of esophageal squamous cell carcinoma 5 to 10 years after the exposure. The next risk factor is regarding mursik. It is a traditional fermented milk that is consumed in certain regions of western Kenya, and this drink has a carcinogen, that is acetaldehyde. So this can result in development of esophageal cancer as well. And the last risk factor is regular ingestion of very hot tea and beverages. In certain countries and regions, there is a habit of regular ingestion of very hot tea and beverage, and this can damage the esophagus, and also in the long run it can result in development of esophageal squamous cell carcinoma. So now that we have talked about epidemiology, particularly we have talked about incidence and risk factors of esophageal squamous cell carcinoma, now let's move on and talk about its pathogenesis, how this cancer is developing. Now always remember, esophageal squamous cell carcinoma develops by stepwise progression. That means as more and more genetic abnormalities are accumulating, the tumor cells are progressing from histologically normal squamous cell mucosa to low-grade intraepithelial neoplasia to high-grade intraepithelial neoplasia, and ultimately when the tumor cells have acquired invasive capability and when the tumor cells can invade the basement membrane, they are becoming invasive squamous cell carcinoma. So always remember that it is happening in multiple steps and it is gradually progressing. Now, tumor suppressor gene TP53 mutation is a very important early driver mutation, and it is usually developing at the stage of intraepithelial neoplasia. Besides this mutation, other key genetic abnormalities include abnormalities in cell cycle regulators like cyclin-dependent kinase 2A and various other genes. There may be abnormalities in the EGFR, that is epidermal growth factor receptor signaling pathway, histone modification, Notch and WNT pathway, etc. Other genetic changes may include aneuploidy, copy number alteration, etc. Now always remember the specific mutation that is required for the tumor cells to become invasive, and the specific mutation that makes the tumor cell invade beyond the basement membrane, that is still unknown. Let's move on and talk about the morphology of squamous cell carcinoma of the esophagus. It can occur in any part of the esophagus, however it is most common in the middle third and lower third of the esophagus. Grossly, the tumor is usually circumferential. That means it is occurring surrounding the lumen of the esophagus, and it is often ulcerated and sharply demarcated. Rarely, the tumor may also have polypoid or polyp-like appearance. On cut section, the tumor will have a grayish-white color, and it may invade part or all of the muscular wall, and in many cases it may even extend beyond the wall into the surrounding soft tissue and trachea. The tumor may also grow towards the lumen, and that type of growth is called intraluminal growth, and that may result in total obstruction of the esophageal lumen as well. If the tumor was located in the distal part of the esophagus, it may often invade the stomach. So what will be the findings under microscope? Microscopically, there will be squamous differentiation, and always remember the degree of squamous differentiation is variable, and most tumors are well or moderately differentiated squamous cell carcinoma. And we will talk about that more when we discuss TNM staging and grading. Now let's move on and talk about the clinical features of squamous cell carcinoma of the esophagus. The most common symptom is progressive dysphagia and weight loss. What do we mean by this term, dysphagia? It means difficulty in swallowing. And what do we mean by progressive dysphagia? It means initially the patient will have difficulty in swallowing only solid foods, but ultimately as the disease is progressing, the individual will have difficulty in swallowing all types of food, both solid as well as liquid food. Chest pain, painful swallowing, these features are also present in many cases. And always remember, there may be chronic gastrointestinal bleeding in many cases of esophageal squamous cell carcinoma, and that may result in iron deficiency anemia. Now, if the cancer had occurred in the upper part of the esophagus, it may invade into the recurrent laryngeal nerve, and that may result in hoarseness of voice and cough. Now, the cancer may also erode the esophageal wall, and that will result in formation of fistula. It is an abnormal communication between two hollow organs, and in this case, the fistula may happen between the lumen of the esophagus and adjacent respiratory tree, and that may result in development of pneumonia. Such fistula may also develop between the lumen of the esophageal wall and aorta, and that may result in severe blood loss. Now, always remember, lymph node metastasis will vary according to region. For example, if the cancer is in the upper one-third of the esophagus, the lymph node metastasis may be seen in cervical lymph nodes. If the cancer is in the middle third of the esophagus, mediastinal, paratracheal, and tracheobronchial lymph nodes may become involved. And if the tumor is in the lower one-third of the esophagus, gastric and celiac lymph nodes may become involved by metastasis. Now, regarding distant metastasis, always remember, most common sites for distant metastasis are lungs, liver, bones, adrenal glands, and kidneys. So always remember these organs for your multiple choice questions. Most common sites for distant metastasis of esophageal squamous cell carcinoma are the lungs, liver, bones, adrenal glands, and kidneys. So how can we diagnose squamous cell carcinoma of the esophagus? Upper gastrointestinal tract endoscopy and biopsy, these are the main tests that we will use, and sometimes esophageal brushing for cytological examination is also done. If there is metastasis, we can diagnose that by image-guided biopsy of the metastatic site, and CT scan and PET scan, these tests are useful for staging more advanced disease and also to assess the response after chemoradiation. So what are the treatment options? Early lesions can be treated by endoscopic submucosal dissection, or they can be treated by esophagectomy. Recall that esophagectomy is surgical removal of either part of the esophagus or the whole esophagus, and then that is reconstructed by using parts of other organs, mainly from the stomach. Now, in case of advanced lesion, neoadjuvant chemoradiation followed by esophagectomy, this is the widely accepted treatment option. Now, the last topic that we will talk about is regarding the staging of squamous cell carcinoma of the esophagus, and we will mainly talk about AJCC TNM staging. Now, recall that AJCC stands for American Joint Committee for Cancer, and their staging system has become a benchmark for classifying esophageal squamous cell carcinoma in order to identify its prognosis and also to select the best treatment option. So this is very important to understand. So as you can see, in this TNM staging system, we have several categories and they have several criteria. So in the T category, we have TX, T0, TIS, and then T1 up to T4. So what do we mean by TX? It means here the tumor cannot be assessed. T0, it means there is no evidence of primary tumor. TIS, always remember, IS stands for in situ. So we know what do we mean by carcinoma in situ. So that is actually this category. So in TIS, there is malignant cells, but those tumor cells, those malignant tumor cells are confined to the epithelium. So in TIS, there are malignant cells, but those malignant cells are confined to the epithelium by the basement membrane. The next category is T1, and here the tumor cells are invading the lamina propria, muscularis mucosa, or submucosa. When the tumor cells are invading lamina propria or muscularis mucosa, it is known as T1A, and when they are invading further into the submucosa, this is T1B. Similarly, in T2 category, what do we mean by T2? It means the tumors are invading the muscularis propria. Recall that muscularis propria is the main muscle layer that is located beneath the submucosa. What do we mean by T3? T3 is when the tumor cells are invading adventitia, and T4 here the tumors are invading adjacent structure, and it is again further divided into T4A and T4B. Regarding the category for regional lymph node involvement, we know that NX means regional lymph nodes cannot be assessed, N0 means no regional lymph node metastasis is seen. N1, there is metastasis in 1 or 2 regional lymph nodes. N2, there is metastasis in 3 to 6 regional lymph nodes. And when the N category is N3, it means there is metastasis in 7 or more regional lymph nodes. Regarding distant metastasis, which is also written as M category, we have two types. M0 means there is no distant metastasis, and M1 is indicating distant metastasis. Regarding histological grade, we have several categories. GX stands for grade that cannot be assessed. G1 is well differentiated, G2 is moderately differentiated, and G3 is poorly differentiated or undifferentiated. Now, you may be asking me, what do we mean by well differentiated, moderately differentiated, or poorly differentiated? Now, always remember, in well differentiated squamous cell carcinoma of the esophagus, the tumor cells are enlarged, they have abundant eosinophilic, that is reddish cytoplasm, and there is also keratinization. Recall that in squamous cell carcinoma, often when there is keratinization, we refer to that as well differentiated. So that same theme is also applying here. When there is keratinization, enlarged cells with abundant eosinophilic cytoplasm, we are placing that in well differentiated category. Cytological atypia is minimum and mitotic rate is low, and the cells remain well ordered. What do we mean by grade 2 or moderately differentiated squamous cell carcinoma? Here there will be evident cytological atypia, and the cells will be less orderly in their arrangement, and mitotic figures are easily identifiable. And the last grade is poorly differentiated, and here we won't be able to identify them as squamous cells. They will be mainly basal-like cells, and they will form nests with or without central necrosis. So always remember, whenever a tumor is referred or graded as poorly differentiated, it means that here the cells have lost their differentiation. We are having difficulty in identifying their origin. They are not looking like the cells from which they are originated. That's why they are referred to as poorly differentiated, and here the cells will be basal-like cells, and they will form nests, and there may or may not be central necrosis. So this concludes our lecture on tumors of the esophagus, and in the second lecture we just concluded talking about squamous cell carcinoma of the esophagus. I hope this lecture was helpful. If you like my videos, do comment, share, subscribe, and let me know. And for my students, I will also recommend you to go through your textbooks to know more. Okay, that's all for today. Until next time, take care and stay blessed. Thank you.